Hello, everyone. On behalf of Geo Institute, it is my honor to welcome you all to the webinar, Public Health Management, Current Needs and Future Roadmap. As we hopefully navigate the end of a devastating pandemic, the importance of focusing on public health systems has never been more dire. Irrespective of our fields of expertise, it is critical that we understand the current situation of public health systems, the challenges it brings forth, as well as technology-driven opportunities of the future. Ultimately, though, it is the people who will make a difference. Right from the managers to the medical professionals, it is essential for all stakeholders to be on the same page and understand how best to contribute towards a robust public healthcare system. This webinar will focus on some of these challenges and opportunities and look towards a strategic, comprehensive, and multi-stakeholder approach to public health management. Before we begin, I'd like to request Prerna Gupta, a member of the senior leadership team at Geo Institute, to give us a brief overview of Geo Institute. Over to you, Prerna.
Thank you, Sanchayan. Next, please. Geo Institute is an endeavor of our chairman and chairperson, Mr. and Mrs. Ambani, to empower youth of India. It is a philanthropic vehicle founded on their personal pledge to build a higher education institution that will play a pivotal role in national development. Next, please. Geo Institute is envisaged to create a platform for strengthening research and innovation ecosystem in India. It will focus on solving some of the most pressing challenges of the country and solving them fast. It will also look up global challenges in due course to make the world a better place. Geo Institute is committed to prepare next generation of entrepreneurs and leaders for advancement of Indian society. Next, please. At Geo Institute, we have a few key defining features. We want to bring world scholars and thought leaders to India. We also, with every academic program, we want to bring in multidisciplinary learning, research-backed, and also innovation-focused learning to the core. We want to inculcate global citizenship through international exposure and hands-on experience, and build skills and attributes of risk-taking and entrepreneurship in all the students. Next, please. The Governing Council of Geo Institute is built with people with diverse backgrounds and experience and a very strong commitment to higher education and the youth of the country. It provides strategic direction to develop Geo Institute as a world-class university. Next, please. In addition to this, we also have constituted a global advisory council with world-renowned leaders, institution builders from research universities. The Global Advisory Council guides the institution on building strong foundation of academic excellence, industry relevance, and social significance. In addition, we've also engaged academic advisors from eminent global institutions to guide and develop various programs at Geo Institute. The 15-year strategic development plan will cover, in 15 years, Geo Institute proposes to start programs in computing and engineering, architecture and urban planning, media, communication and journalism, arts, humanities and sciences, management and entrepreneurship, law, governance, policy, and medicine. We also will have campuses for residential education for about 10,000 students and about 1,500 international students and about 1,000 faculty in due course. Next, please. To begin with, we are launching our postgraduate programs this year, and we will be focusing on programs in artificial intelligence and data science and digital media and marketing communication in year 1. Year 2, we would start programs in public health, sports management, and journalism. And in the first phase, our focus is to launch the seed programs, which will lead to then development of full-fledged schools, as I mentioned earlier. And these schools will then have programs at undergraduate level and also at PhD and postdoc level. After a growth phase, we expect in year 11 to 15, Geo Institute to mature into with specialized disciplines that are interdisciplinary in nature, and also focus on enhancing student experience and strengthening our global brand. Next, please. Geo Institute is developing its startup campus at Olve, Navi Mumbai. This campus is spread across 4 lakh square feet of constructed building over 52 acres with green spaces, sports facilities, etc. It is located in close proximity of the new international airport and is also well connected to Mumbai, South Mumbai, and Navi Mumbai. Here are a few images, as you can see, of our campus, which is operational in Navi Mumbai. Thank you very much.
Thank you so much, Reena. I'd now like to request Dr. Gustad Davar, who is the former medical director and consultant vascular, thoracic, and general surgery at Sir H.N. Reliance Foundation Hospital, Mumbai, to give his opening remarks. Dr. Davar is presently working as the medical advisor, as mentioned. Before this, he was the medical director and consultant vascular, thoracic, and general surgery at Sir H.N. Reliance Foundation Hospital in Mumbai. He has contributed to the development and organization of multi-organ transplant program in the state of Maharashtra since its inception in 1994 and is member state advisory committee for organ transplants. In addition to his professional credentials, Dr. Davar is indeed passionate about public health and leaves no stone unturned in ensuring its development in academic as well as professional sectors. Over to you, sir.
Thank you, Sanchayan, for the introduction. Well, first of all, let me welcome you all to this first webinar in public health management. We have been working on this project for quite some time now, and finally, this is the first webinar, so it really gives me a great pleasure. So we all know that public health continues to be a great challenge in India for 2 reasons. One is for the large population, and secondly, we have stretched resources. We have limited resources. So one of the things is that the millennium goals which were already set have not been achieved. So a lot of work remains to be done, and still more health challenges are coming up. So in India, we have a very typical problem that we still haven't overcome the infectious diseases and other problems. But to that, we have added lifestyle diseases like hypertension, diabetes. We are called the diabetic capital of the world, which is not a very good thing, but the number is increasing. We are having large number of cancer patients, and a lot of these people come for management pretty late in the stage. So one of the ideas is that if we have a good public health institute, which will look into these issues and bridge the gap between prevention and management, we will achieve a lot. So one of our ideas is to create a dedicated public health cadre, which will be the most important requirement to bridge this gap. The program will emphasize on epidemiology, various health emerging challenges, public policies, and policy making. The course will prepare the students to take on these challenges as they arise and also help the active management of the people. We at Geo Institute of Public Health have given this the highest priority, thanks to our chairperson, Mr. Mukesh Ambani and Neeta Ambani. they have agreed to put this in the first phase, which shows that how important they consider public health in the scheme of things. Also, I would take this opportunity to thank our Chancellor, Dr. Mashelkar, and our Vice Chancellor, Dr. Deepak Jain, who has been a source of inspiration. Thank you, Dr. Deepak. And our Director Palak Seth, who has been guiding and helping us along this program. My special thanks to Dr. Mohan Chalappa for having agreed to mentor this program in spite of his busy schedule. And I would like to thank Dr. William Ward, who is going to speak today. He has been spending a lot of time with us to develop this program. And last, not the least, is Dr. Samantha Clark, who has been helping us too. And I would like to thank all of you for joining us for this first program. And I hope you have a good take-home message. We'll be having more of these programs later on, and maybe we'll have executive courses. And by 23, we hope to start a certificate course. So thank you all for joining us. Over to you, Sanjay.
Thank you so much, sir. I'd also quickly like to take the opportunity to welcome Michael Keller, who is the Vice Provost and Ida M. Breen University Librarian and Director of Academic Information Resources at Stanford University, who is attending this webinar. Dr. Keller is an integral part of our Geo Institute Digital Library initiative and has been involved with the initiative right from conception and continues to be a great source of guidance, support in every way possible. Welcome, sir. Hope you enjoy the webinar today. I now like to request Dr. Mohan Chalappa, who is the President Global Ventures and Executive Vice President at Johns Hopkins Medicine International USA, to say a few words. Dr. Chalappa is involved in developing international clinical consultancy activities, especially in the areas of clinical care program development, quality systems implementation, and the use of information technology in healthcare. He has been instrumental in securing and establishing various clinical, management, and enterprise developmental initiatives and engagements of Johns Hopkins Medicine globally. Over to you, sir.
Thanks. Thanks, Sanchan. Thank you very much. Good evening to all of you, and good morning to my colleagues here in US. I wanted to really say a few words before I request my colleague, Professor Ward, to give his lecture. I'm very much honored to be facilitating this
Mohan, I will speak at the end, just to be sure. Right, Sunshine? I will do the closing remarks.
Yes, sir. Got it, sir. Yeah.
Sure. Absolutely. Wonderful. Looking forward to that. As I said, I'm going to make some brief remarks before I request Professor Ward to give his lecture. I'm going through first of all, I'm very honored to be facilitating this initiative by the Geo Institute to do this. Thanks to the leadership, thanks to Dr. Palak and then other leaders who are actually facilitating this very, very transformational sort of an initiative to do that. Going through the memory lane, I'm looking at it in 1916 when the Johns Hopkins School of Public Health was established, I think by a funding by the Rockefeller Foundation. I think the comments and the statement which was made at the time that this institution would be homogeneous in culture and it will be animated by very high ideals and it will be efficiently led. I think it sort of resonated with me because again here with a few of us who have association with Johns Hopkins here and with a very, very highly acclaimed team from Geo joining together to create this institution. And I do hope that we will be reaching the very high levels in the years to come. As Dr. Dawa mentioned, I think healthcare has seen a lot of challenges in the last 2 to 3 years. We had to face unexpected, ways in we would be challenged. First of all, emerging diseases, the variants which are coming in sequence quite frequently, shortage of manpower, access to healthcare, which was already there between rural and then urban, rich and the poor, which got very much accentuated by the epidemic. And it also showed that healthcare is not separate entities. It is a one entity. A healthcare CEO, system CEO has to get up in the morning and actually talk to his public health executive, expert, and then ask him what's happening in order to be prepared for his hospital to manage that. The same way the public health executive needed the support of the healthcare system and the diagnostics to really get the better outcomes of what needed to do. Therefore, it's one whole system. And therefore, we decided that we should take on healthcare strengthening as an important first series of lectures to really focus on that particular topic. And here we have Professor Ward to address those topics. Some of the topics which actually we will take on as an individual focused area in the future webinars as we move on to do this. Therefore, with this short note, before I request Professor Ward to come in and give his talk, I also wanted to take a moment to thank Dr. Jain, Dr. Palak, and also Prerna for helping to make this happen. And there is also a silent team behind Naman Singhal, Ritu Mishra, Sanchayan Bhattacharjee, who have actually made this happen. I wanted to thank all of them. And with this, on to you, Professor Ward.
Thank you, Mohan. Good evening, everyone, and welcome to the program. It's my pleasure to be here to talk about strengthening of public health. I'm going to share my screen, I hope, and show my slides. And there we go. It looks like we will be off in a second. And so there we go. So as Dr. Chalapa kind of mentioned, the current health system around the world is really suffering from 2 years of total overload, in which we have had more patients than we could take care of, fewer staff than we would need to take care of them, shortages of a variety of things. And the prevalence of infectious diseases continues to grow. So it's not like COVID was a surprise or should have been a surprise to us. I think we should have been thinking about that and trying to figure out how we were going to deal with that as it came towards us, as opposed to, oh, look, it's here. The provider sector has therefore been overloaded, overworked, burned out, worn out, stressed beyond belief. And the challenge I think that we're going to face is there's another something coming. Will we have recovered quickly enough to deal with that? Or will it compound the dilemma that we already have? So when we talk about what we need to do and where we are, we've got to deal with things like resource shortages. But mostly I think we need to deal with things like management deficiencies. And we have taken people and we have put them in management positions because they were the best technical person, the best physician, the best nurse, whatever, but we haven't really trained them in how to manage resources and how to lead people. And that's what we're about in this discussion today, to talk a bit about what we need to do to get there. And in order to do that, I think it's important fundamentally to understand the process of healthcare. Healthcare is all of the skills, all of the resources, all of the knowledge, the technologies, and everything else that we have available to us applied in an orchestrated way to provide care to the patients who come to us expecting that they will be taken care of. It's a process as opposed to a single intervention. We sometimes think of it as, oh, it's an intervention. I'm going to go see my doctor. Well, I went to see the physician that I see yesterday, and I had 5 different encounters with 5 different people, all of whom had to be orchestrated the right way. And so we have to focus on that, and yet we don't. What happens in health services is we manage departments. We need to manage process. And so we need to develop our next round of leaders who understand systems thinking, who understand connectivity between and among all of the different departments that are brought together to provide care for a patient. And I like to think of it using the analogy of a spider and a spider web. And if you examine spider webs for a little bit, you'll notice that it doesn't matter where the spider is. When a fly lands on the spider web, the spider knows dinner is served. And they know whether it's a slight, a really big feast or a little snack or what have you. But they understand that regardless of where the fly is and regardless of where they are. And the reason for that is that all of the elements of that spider web, all the pieces of spider silk are connected. And one of them being touched by the fly sends a message, a ripple through all of them. And the spider knows where the fly is. If, on the other hand, you were to disconnect all of those strands of spider silk, leave the strands themselves, but disconnect the little connections here and here and here and so on, the spider will die because the message will never get through that dinner is served. And that, over the years, I have discovered to be a very good analogy for what we do in health services, in our hospitals particularly, but elsewhere in the system. And so the patient is at the center of that spider web, and all of the different departments, from social work to nursing, to transport, to the labs, pharmacy, and so on, all of those departments need to be connected, talking, vibrating, if you will, with information about that patient and about others in the institution. And if we stay connected like that, and that's what a system does, so if we stay connected like that and manage the process, as opposed to managing just the imaging department or just the pharmacy, we will be able to provide the kind of care that our patients come to us expecting to get. So in this notion of orchestration, from a patient being admitted to a patient being discharged, we have to make sure that the assets of care, nursing, other clinicians, surgeons, technicians, and so on, the different procedures that we do, plus all the medications, supplies, and all the rest, the technologies, the instruments, that all of that is orchestrated in such a way that that patient continues to make progress day after day after day until they are finally discharged and sent home. And so where we need to be to make all of this happen is that we need to be prepared for the next disaster that comes along. We can't be just sort of sitting around saying, well, we got through that last COVID-19 thing, and so that's great, we're back to normal. We'll never be back to that normal. And so we have to have response plans for when disasters strike. And those disasters can be natural disasters, they can be disease outbreaks, whatever. But we need to have those response plans with contingency plans, policies and procedures that say, how are we going to deal with certain things? What are our priorities in terms of providing services? How do we triage patients? If we only have one patient that we can care for, is it a 20-year-old pregnant woman, or is it a 95-year-old woman who has lived most of her life? Which one do we give the life-saving treatment to if we only have one? We need to understand about standby bed capacity. Part of the issue that we saw in the United States was we ran out of beds. And so there were no place to put the patients. But further, and compounding that, is the fact that when the beds became full of COVID patients, you had all manner of other patients not being cared for. And the mortality for those patients rose significantly. And that's just a terrible shame. But patients deferred care, delayed being seen, couldn't get admitted this week, had to wait a couple of months, and so on. We may need to look at convertible spaces that serve one purpose today, but can easily be converted to care space tomorrow. A colleague of mine in New Jersey has a conference center at the back of his hospital. Within 24 hours, that conference space can be converted to a 48-bed unit with all of the wires and the pipes and the oxygen feeds and the gas and all of that already there. All he needs to do is wheel in the beds and care for patients. It gives him a tremendous amount of surge capacity. He paid attention on 9/11 and saw what happened to hospitals in the New York area that were literally swamped by a tidal wave of patients needing to be cared for. And so he went out and built what he needed, a conference center, but what he could use as an alternative site. And that's the sort of thinking we need to be employing. We need to look at critical staff reserves. How do we bolster our staff? How do we go from caring for 200 patients to caring for 300 patients when we know that we can't do it with the same number of staff? And so do we have things almost like a National Guard where you can be called back into healthcare to take care of patients when a crisis arrives? A friend of mine likes to talk about emeritus staff. These are people who have left their employ, they've gone off to retirement, but they've only been retired for a couple of years. So they're still relatively competent in what they're doing, and they can be called back in to ramp up the staffing levels. And the same is true in terms of supply reserves, medication reserves, and the like. Having extra inventory on a standby basis in order to supplement what we have in-house is a prudent thing to do. But most of all, we need to develop the future cohort of leaders and managers. We need to make sure that we have the right people with the right abilities in the right places at the right time. That requires foresight, but it also requires development of that cohort of future leaders and managers. And so what we need to do is leadership and management development. We need to take people and give them the skills that they need to have to be process managers, to be systems thinkers, to lead people, to manage inventory. And that requires that we train them. And there are so many different ways that this can be done, from little mini programs to cohort training, where you train everybody from a hospital at the same time with the same speakers and the same content so that everybody gets it at the same time, hears it the same way. We've seen week-long intensives where people go away for a week and learn and then come back to the workplace and in fact come back and share what they've learned. We have blended programs that are done partly as a video and partly in real time, or in today's environment, partly as a video and partly via a virtual presence like Zoom. Refresher courses to bring people up to speed on what the latest theories are, what the latest practices are, so that they can have the best, most up-to-date skill set that's possible. In the United States, state hospital associations do this. And that, I think, is something that is applicable to just about any place. Local jurisdictions setting up their hospital associations, public health associations, and so on, to do the training, to bring in the speakers, educate people. That's kind of the grassroots. Professional associations do a similar thing. You'll see the American College of Radiologists doing a program for their members and so on. So professional associations for surgeons, for physical therapists, for lab managers and so on are out there being done. Private industry, General Electric, Siemens and so on, all offer programs for the individuals who buy their products to bring them together and get them trained. And then lastly, university degree programs and certificate programs that are university-based, that take advantage of the breadth of skills that are available in a university setting to influence and train that next group of public health leaders and managers. The key elements that we need to infuse, if you will, into these folks are the following. And there's a whole list of them, nearly a dozen of them, that they run from the notion of effective governance all the way down to the use of artificial intelligence and robots. These are the things that are going to help us in the future. And we need to make sure that our leaders and managers are aware of them, take advantage of them, and use them to make care at every level better for the patients we serve. So let me just go through for a second what each of these involves. So corporate governance, the first one, and I decided to start at the very top of the organization, the governing body, which holds everyone accountable for how they are using the resources that are available, how they're making their decisions, how they're providing care, and so on, for the patients that the institution serves. We, in effect, stand in the stead of those patients, that population of people who can't all hold the institution accountable, but rely on us in a fiduciary way to watch out for their well-being. In many respects, it's, you know, like parents watching out for how their children are doing in school. We need to make sure that the folks that are filling those positions understand what their roles are, what their responsibilities are. It's not an easy thing to be a board member. It's a job, and it's an important one, and it takes an investment of time and energy to understand issues, to read the materials that are sent around. I was on a for-profit board a number of years ago. The board packet could be 500 or 600 pages long, and I was expected to have gone through all of it and have my questions ready when we got to the board meeting. And it took me several days to do that. So there's a commitment of time out there. But in addition, we want to make sure that the board encourages the leadership of the organization to do its best, sets up the proper goals and objectives, supports the notion of strategic planning, hires the CEO, and sees that things are operated properly. But, and this is a big but, they don't manage the institution. And institutions that have difficulties, generally you can trace back to a board that tries to manage. And I know as a former hospital executive, when I've been on boards, it is always the hardest thing for me to just say, I'm not a manager anymore. I'm just governing. I'm overseeing what these folks are doing. I'm not deciding what color the paper should be. And I'm not making a decision whether it should be a Siemens machine or a GE machine that we buy for imaging. I'm just making sure that the leadership team has done its due diligence and is making the best possible investment that they can. Human capital, incredibly important. When we look at health services, we, I think, tend to see brick and mortar, the facilities that we have and how wonderful they look and so on, and the equipment that we have, the technologies, the machineries, the robotic surgery systems, and the MRIs and CTs and PET scanners and the like. But the reality is you need to have access to a number of resources if you want to be successful, and access to capital certainly is one, infrastructure and technology are others. But this bottom right quadrant, people, is the most important element. We want folks who are engaged in what they do, that have bought into our mission, our values, our standards, and so on, that can be as productive as possible, who come to work each morning with a positive attitude that says, you know, we're going to do some more good today, as opposed to seeing people who are sort of, you know, just going through the motions, or it's, oh, I got to get up and go to the hospital today. We want folks who are engaged, who believe in what we do and make what we do happen in the best possible way. What that means is that we must invest in that staff, just as we would invest in preventive maintenance for our CT scanners or preventive maintenance for our vehicles and so on. We need to do sort of preventive maintenance for our staff, skill building seminars that help them to understand what's the best way to put in a central line. What's the best way to think about inventory management? Should everything be stocked at one end of the hall, or should we have dispersed little supply servers down throughout all of the patient rooms? And those kinds of skill builder programs help us to have an engaged workforce, because it says we as the leaders are investing in you. We care enough about you that we will make an investment. Too often, and I think eventually we will talk about human capital in much greater length, too often I think we see people as just another resource. That's an expendable resource, and it's part of expense. In fact, we talk about, salary and benefits expense on the P&L. We really should be talking about human capital as an asset of the company, and assets are safeguarded. Expenses, well, we'll cut some here and cut some there. We don't worry about them the same way. So we need to do that. With respect to our managers and leaders, we need to develop them. So they need to get some training as well. And more important than just training them, we need to have succession planning in place for them. A long, long time ago, when I was young and starting out in my career in accounting, my boss said to me one day, as we were talking about my performance and how things were going, he said, you have to have your potential successor groomed in order for me to promote you up and out of your job. I've got to be able to see that there's somebody ready to come along and fill in. And so succession planning has gotten to be an important element as we look at human capital. How do we replace the administrator in the imaging department? How do we replace the CEO? Is there a plan to get someone to step in as the new chief operating officer when the current chief operating officer goes somewhere else to be the CEO? And so we need to be thinking about all of these different elements around the notion of human capital. It's our biggest and most important investment. Financial management, money management is critically important. How do we develop our operating plans? Or an operating budget for revenue, for salaries, for supplies, for the volume of patients we're going to be taking care of? How do we blend that with the capital budget so that we have the equipment and technologies to support that? And how does all of that flow into cash flow budgeting and cash flow management? Because if you run out of cash, you're out of business. So how do we develop business plans for a new initiative? Not an annual operating plan, but a business plan for, we've decided to get into bariatric surgery. Let's put together a business plan for that. How do we do that kind of stuff? What kind of analysis should be in there? What should we be looking at? And so on. We also need to look at, we also need to look at the notion of resource maximization, eliminating waste, eliminating redundancy, eliminating idle time for our staff and so on. How do we go about making sure that that happens so that the scarce resources that we have can do more care, can support more patients, can help our institution do more with the same amount of resource? And then lastly, it's important under the broad category of financial management to look at decision support analyses, a variety of different kinds that can help us make prudent decisions on the business side, keeping in mind that the business side is not the only side we want to look at. We've got to balance the business with the clinical. And so we don't make decisions solely on the basis of, well, this is great for business. Is it great for patient care? And vice versa. So we try to keep those two in balance. And there are obvious ways to do that. We'll talk about that in more detail in another class. Dashboards. I was talking to some students the other night at Hopkins, and the subject of dashboards came up, and somebody said, how many metrics should you look at? And it got us into a discussion about dashboards. The problem that we have is that the management reports that we typically receive are basically columns and rows of numbers. And I like to joke around with folks that the winning lottery numbers are in that report. The problem is you can't find them in time to play those numbers. But management wants to be driven by data. And so how do we get data to managers in order that they can understand it, absorb it quickly, and take action based on that? And that's where dashboards come in. 3 different kinds: operational, tactical, and strategic, that help us understand how things are functioning on a day-to-day basis, how our enterprise is functioning on an ongoing basis. And this is where boards get to think about looking at our dashboards. And what's going to happen in terms of long-term success? How are we positioning? How are things going? Looking forward in time to say that, 3 years from now, we're going to be in a better position, or 3 years from now, we're going to have a challenge. We need to be focusing on the limited numbers of dashboard indicators that tell us the most important elements, and do so in a way that is quick and easy to view and assimilate, so that we don't have to read and read and read, but we can just look and learn. And then based on that, we can take action. And those dashboards need to be looking at a lot of different compass points. They need to focus certainly on quality and patient safety, because that's the number one role that we have. We've got to provide quality care, and patients have to be safe. But they also want to look at finance. They want to look at the patient experience, and they want to look at human capital. And I know from my own board experience, we see these kinds of dashboards at every board meeting that talks about what's going on qualitatively. In our human resource committee, we talk about employee engagement, turnover rates, and so on. But what we're looking at are key indicators, KPIs, key performance indicators, that give us the quick look so that we can quickly use them and take action. Clinical quality and patient experience. Now, I really wrestled with the notion of whether to put this as the very first slide or to hold it for here, and I decided to hold it for here. But this is the most important thing that we do. This is the gold standard, if you will. We want to make sure that we are providing, as it says, safe, patient-centered, timely, effective, efficient care to every single person who comes right in the door. And that means the right care in the right setting at the right time. We don't want to be delayed. We don't want to do step number 3 before we do step numbers 1 and 2, and so on. We need to orchestrate that as well. But quality supports business success, because patients and their families look to where to go in terms of quality. There's an old 4x20 rule that I've seen in place for a long, long time, that says that if you do the right thing, folks will tell 4 people. If you do the wrong thing, they'll tell 20. So we got to leverage on that. We have to do the really right thing so that 4 people hear that it's a good thing, as opposed to 20 people hearing that it's not so good. And that comes into the notion of consumerism, where people are now becoming more and more aware of where they want to go, what's happening qualitatively, and so on, where they look at quality, where institutions look at quality as a market strategy, where, if you come to our institution, we will not make a medication mistake. And that's all reputational, but that's the kind of thing that people look at. But they're also concentrating on that patient experience, because it doesn't matter just how you took care of my spouse. Was the food warm when it was supposed to be? Were the staff friendly and engaging? Did they smile at me? Was parking easy? Was it easy to find where my relative was? Or did I wander around in a maze? And so we've begun looking at this notion of patient experience as an important element of clinical quality and patient safety. And then there are a number of, as it says, low cost, very simple approaches to improving efficiencies clinically, to improving outcomes clinically. You can avoid ventilator pneumonias just by elevating the head of the bed to 30 degrees. Well, is that simple or not? You can improve on your patient experience by listening properly to patients, making eye contact, being empathetic, and not looking away, not listening to the patient sort of, but looking at your phone or whatever. I have a physician that I sometimes see. I try not to, but when I do have to see him, I'm sitting here, I'm facing him, he's not looking at me. he's looking over to the side at his computer screen and he's typing. And I sometimes feel like saying, excuse me, Steve, did you notice that I was sitting in the room next to you? Could you make eye contact? That's the kind of thing that influences patient experience. How long we have to wait for an appointment to be made and so on is another element. A focus on population health is very, very important because population health gets at the wellness, the overall wellness of the community that we are set up to serve. And so are we keeping people healthy? Because if we keep them healthy, that can reduce the demand for costly hospitalizations. So if I can take a population of patients and prevent them from getting diabetes by having programs on proper diet, nutrition, exercise, etc., that's inexpensive. If they become diabetic, I now have a chronic illness that's going to be tapping in to health resources for years and years and years. So investing in the health of that population, whether it's health screenings, health fairs, education programs, and so on, doesn't really matter as long as you're focusing on keeping that population as well as you possibly can. It winds up giving us lower hospital costs and lower provider costs per patient globally, which is a good thing because that allows us to take that resource that might be wasted and apply it so that we have additional capacity for when we have issues like COVID coming along or COVID-2 or whatever is next in line. That allows us to reduce global healthcare costs, and that's always been a good thing. The cost of healthcare skyrockets all over the place. It's just exceedingly expensive. And as one of the founding fathers of the US used to say, an ounce of prevention is worth a pound of cure, and it certainly is. I know a hospital in Maryland that is going so far as connecting their emergency room with a series of nursing homes in their area to be able to intervene in the nursing home, care for the patient there as opposed to that patient needing to be transported to a very high expense emergency room. Building teams of people to do things. Remember, I talked earlier about the fact that we are in a system and we need to be thinking about systems and so on, about the interplay of all the various departments back and forth. That's what team building gets to. Teams of people who know how to work together, who aren't just thrown together. And I've seen that done where we'll just go, you, and you. No, that doesn't work. When you put a team together, you have to make sure you have the right skills on that team. You have to make sure that the people are compatible on that team. You need to have some people on the team that are very creative and some people that are a little bit of a naysayer to say, wait a minute, are you sure we want to do that? To hold your feet to the fire, so to speak. You want to have somebody who doesn't understand what you're working on because they will see things in a different light. And so if I'm looking at improving throughput in the emergency room, for instance, I want to have somebody who has no idea about emergency rooms on that group so that when that team is looking at how do we make the emergency room flow better, let's say I'm that person who doesn't know, I can say, how come you do that? How come that happens? Have we ever thought about the following? You want a different perspective, and that person can provide that. We need to empower those teams. We need to allow them to make mistakes. We need to invest in them. One of the best teams I ever saw was given $200 to spend any way they wanted to get an improvement to be made in the ratings for the nutrition department. And so there was one of the finance people was on that team, somebody from nutrition service was on the team. There were a couple of nurses on the team. They had a position of patient advocate who they put on the team and so on. And I mean, they were done in probably 2 or 3 weeks' time, as I recall. They didn't use any of the money. So they took themselves out to a fancy dinner. And you know, the first reaction that the CEO had was, wait a minute, why are you doing that? But then his second reaction as he began thinking about it was, well, we said use it any way you want. By golly, You guys got down there, you worked really hard, and you're rewarding yourself. That's a good thing. So look at those teams, get them set up, and have an environment in which they can make mistakes, learn from that, and move on. Rapid changes can be done. We don't have to study things for 6 months. We can look at stuff for a couple of weeks, make an adjustment. Innovation. Every other industry that I have ever been involved in, whether it's manufacturing or the airlines or hotels or whatever, looks at the notion of relentless innovation. We tend to be innovative clinically, but we don't tend to be innovative operationally. And a friend of mine, Peter Pronovost, pointed out one time that there is a ton of money that's invested in clinical investigation and research into how to better care for patients with diabetes or heart disease or what have you. But there's nothing invested basically in how do we manage our inventory better? How do we keep staff engaged? How do we get communication amongst our different departments to improve? And that's the kind of thing that we need to have. So we need to set up an orientation in our organizations that says risk-taking and critical thinking, out of the box thinking, is rewarded, is encouraged. And even crazy ideas, quote unquote crazy ideas, are considered because there may be a germ of truth in that crazy idea. There's a quote from Richard Branson who said, and I'll get this a little bit off, but something along the lines of, Uncle Jimmy told me a long time ago, when everybody thinks your idea is absolutely crazy, you just might be onto something big. We need to remember that. We need to be competitively differentiated from other people. We need to be able to look at our innovative strategies in clinical care, our innovative operational strategies, and so on, as a way to differentiate ourselves from all the other groups that are out there. So how do we make things different enough that we can use that as a competitive advantage? We need to look at financial performance and business growth. We need to look at how effective are we in using our resources? Do we have a lot of waste? Do we have things ill-positioned? I saw at a trade show a number of years ago, I saw an architectural competition where architects in the area came in with some of their latest hospital designs. And they put up both hospital renderings, but also floor plans to see how things were laid out and the like. And as I was studying those, I noticed that one of them had a blue ribbon on it. I guess that was the best one they had. And so I went over and I looked at it. And as I looked at it, I noticed that the nursing unit was longitudinal. The supplies were all at one end of that long hallway. The patient rooms were at the other end. Now, somebody figured out that that was an efficient way to stock the inventory. Right off the elevator, go into the supply room, dump it off, boom, we're saving a lot of time in supply chain. The only problem was the nurses had to shuffle up and down and up and down and up and down the hallways to get to those supplies, which meant their amount of time of hands-on with patients was compromised. We were not getting the most out of one of the most critical resources in the organization, the nurses. We were making life easier for the supply transporters, but the nurses were paying a heavy price for that. And so we need to be careful about that. We need to look at clinical outcomes. How can we operationally improve the way we do things that will have a positive impact on clinical outcomes? And there are ways to do that. And then lastly, in terms of innovative approaches, the notion of population health. Does everybody need to come into the hospital? Does everybody need to come in for a doctor visit? Can we do visits over the phone? Can we do them via telemedicine and so on? And then finally, this notion of artificial intelligence, robotics, telemedicine, and so on are all out there, and they're all just beginning to come to the forefront. We've discovered, for instance, in the US, that everybody doesn't need to go to the doctor's office. to be seen, that we can be at home and we can sign in via our computer, see the doctor and talk back and forth with that physician and so on. My wife has had visits like that. I've had visits like that. Countless friends of ours have done the same exact thing. You just sign on and off you go. That wasn't around really before COVID. And so I guess it's necessity is the mother of invention. But dealing with things like how can we use artificial intelligence to improve outcomes? Is there a way that it can look at how we are efficient or inefficient with our resource consumption? Can artificial intelligence, manage inventory better than we do? Can it point to things that are coming, haven't arrived yet, by looking at trends and patterns and so on? There was a fellow named Naismith a long time ago who wrote a book called Megatrends. And what he focused on was little tiny events, little things that foretold bigger things to come. Artificial intelligence, the use of big data and big data sets, business intelligence, and so on can help us to be more effective in what we do. Robotics for surgeries, but not just for surgery here, but for surgery elsewhere. A friend of mine who's the chief of urology at a hospital in New York talks about that in the remote parts of North Dakota, there is no real need for a urologist, because if somebody needs a urological procedure, they're done typically with a laparoscope. And so he can do that from New York. And in fact, when he was in Baltimore a number of years ago, he took out a gallbladder in Munich, Germany. Patient was in Munich, he was in Baltimore. That kind of thing allows us to expand the resources that are available to people. It allows us to bring the urban care into the rural environment and provide patients with the kind of care they need to have, but that they're not even close to geographically. And then lastly, telehealth. From primary care to specialist consultations, we're seeing all sorts of things happen in telehealth in terms of monitoring patients both in hospital and in home. And so there's telehealth that's monitoring patients and how they're doing as they're lying in their bed, and that automatically alert people that something is about to happen. We can monitor patients in home to make sure that they're doing what they're supposed to. We can tell whether they're taking their medications or not. We can take a diabetic patient, tell them when they get out of bed in the morning, make sure you take your medicine. And oh, by the way, go and stand on that scale that's connected to the internet. And that scale will weigh you, and it will take the temperature of your feet, both of which are important in managing diabetes. And it will send that data to a provider. Now, the provider can then say, well, we'll use artificial intelligence to keep track of that. And if we see something developing, a micro trend developing, we can force an intervention with that patient and prevent an expensive hospitalization 2 weeks later when we happen to find out that their circulation of their feet is not what it's supposed to be, and they've gained another 10 pounds. So all of those things, I think, are important for us to focus on and to get our people involved in as we try to make the most of public health. And so at that point, I would be more than happy to take any questions that anybody has.
Thank you, Bill. That was great.
You're welcome.
Always a pleasure to hear from a giant in the field like you.
Now she means giant in the field because I'm 6'7" tall. That's what she means.
Every sense of the word. So we have a couple of really great questions. And one of the first one regards, you were talking a lot about preventative care. And so they were asking if, kind of focusing more on preventative care is the best way to alleviate some of the current burdens on healthcare systems. And if you could also talk a little bit more about some effective preventative and population health initiatives that you've seen kind of implemented in this regard, or in this kind of effort to focus more on preventative.
Well, the whole notion of preventive care is the ounce of prevention is worth a pound of cure. But it really is, if you can, let's say Samantha decides she wants to start smoking, okay? And on and on and on she goes for 20, 30 years. And the next thing you know, she's got chronic obstructive pulmonary disease. She's in and out of the hospital with respiratory issues and so on. She's racking up some sizable bills. If I can spend a little bit of resource to keep her from smoking, prevent that from happening, then she goes through her life and doesn't need the hospital. She doesn't develop COPD. She doesn't develop heart disease and so on. And so she becomes a cheap patient, if you will. No offense, Samantha, but it's very inexpensive that way. From the standpoint of telemedicine and some of the things that I'm aware of in terms of population health, Upper Chesapeake Medical Center in Bel Air has an arrangement with Lorien nursing homes, in which the Lorien nursing homes have a, what's the best way to describe it? A little R2-D2 kind of robot that roams around, that has a screen and has cameras. And the physician at the other end of that little robot can see the patient. And so we're in a nursing home. Grandma doesn't seem to be doing too well. We're trying to figure out what exactly is going on. And the first thing that most folks do in a nursing home setting like that is they pick up the phone, call an ambulance, and send the patient to the ER. Not with Upper Chesapeake. With Upper Chesapeake, they hit a couple of buttons and they're connected to an attending physician in the emergency room. Checks out the patient. The nursing home is able to do some, simplified kinds of testing and so on. They run through the symptoms, they run through the history of the patient and so on. And they figure out that, oh, here's the problem. This patient isn't having enough thyroid hormone. Their thyroid gland is off. They need to be taking some Synthroid. Well, curiously enough, they've matched their formularies. And so what's in the hospital formulary is, to a less grandiose amount, in and available at the nursing home. And so they can say to the nursing home physician, oh, the problem is she's hypothyroid. Go on over and put her on 50 milligrams of Synthroid, and that should take care, 50 mcgs of Synthroid. And let's see how that goes, because that's what her issue seems to be. Or they can look at a patient and say, wait a minute, we've got some issues with congestive heart failure here. Or we can take an EKG strip and say, uh-oh, AFib, bring them to the hospital now and intervene in the acute setting sooner. So either way, by intervening in the health system for an acute patient sooner, avoiding patients getting disease entirely, or allowing patients to be seen in a least costly setting, nursing home, or for that matter, at home, is something that's out there. Now, I have a, I don't remember what it's called. It's a little device that I have that connects to my cell phone that will tell me what my cardiac activity looks like. And so it can detect AFib, it can detect a few other things, and it can be sent to my cardiologist. So I don't have to go to the ER and say, I think it was this, I'm not feeling real good, whatever. I can just send him a strip and he goes, Bill, haven't I told you not to eat pepperoni pizza 3 times a day? Stop it. You've got gas. You don't have a heart problem. That's available now. And that's another example. That's $100. An example of how you don't have to go to a high cost provider setting to take care of things.
Thank you, Dr. Ward, or thank you, Bill, sorry. That was very helpful. We have another good question. Can you talk a little bit about how clinical managers can work more with semi-urban or rural communities? And you touched on this a little bit when you were talking about the urologist example, where they can work, kind of do telehealth or work remotely. And they brought up the example of in India, the government's working on delegating non-communicable disease identification and follow up to the community at the community health worker level, rather than kind of the physician level. Is this kind of an area where you see a big opportunity for things like telehealth, or, you know, have you seen this in other communities where it's tough to kind of balance that kind of desire to get accurate care, but also be able to provide it to the greatest number of people? Is this a kind of an opportunity that's ripe for telehealth?
Oh, there are so many opportunities for things like that, what you mentioned there about the community health worker and a physician and so on. So what you can do technologically to connect a public health worker, a community health worker, with a backup physician, a backup specialist, so that, you know, probably 95% of what a community health worker sees is pretty much routine. They're trained well enough, generally speaking, to be able to handle most things. But when they get that one that's a little bit weird, you know, we've not seen this before, this is really kind of odd, they have the ability, either via telemedicine, by telephone, whatever, to get in touch with a specialist in Mumbai or wherever, and have that backup. Now, the military in the United States has been working for a number of years on improving battlefield medical care. And they have been working on, I don't know what exactly I would call it, a smart face shield, let's call it that a medic on the battlefield puts this shield on, and a physician in a rear area can see the patient that the medic is dealing with, and can look at that patient and guide the medic in providing the care to that patient. And so what happens there is you've got a corpsman who's had some training, but you've got a physician who's a skilled trauma surgeon or a skilled whatever, and can provide information to that person as they provide care. There are systems available. If you are doing, for instance, laparoscopic surgery, where you can have an expert on screen moving a cursor as they watch what you're doing and show you where to make the next incision remotely. So that if I'm doing, get ready, Mohan, I'm going to take your name in vain. So if I'm doing a laparoscopic surgery and I'm a little bit shaky here, I can have Mohan get on his iPhone, call up and see the same screen that I'm seeing, because remember, laparoscopic surgery, you're not looking at the patient, you're looking up at a TV screen. He can see the monitor just like me, and he can use the cursor to go, Bill, this is where you make the first cut, and this is where you make the second. Am I right, Mohan?
Yep, right.
He would probably charge me a sizable fee for that, but that's another way where I don't have to have his particular skill set, the best in the business. I can be sort of an average kind of surgeon, and I can get away with, when I've got a tough case, having that availability to me. And that's out there these days, available.
Yeah. Mm-hmm. Yeah, just to chime in, I think you're right, Bill, in the sense that is that technologies today makes everyone, to some extent, develop the skills and expertise, you know, at a very short a time on a very specific type of an activity. And that needs to be used in all levels. Just to give one aspect of it while you are there, Bill, could you also give some thoughts about some of the work on the management of these non-communicable diseases and other things, as Samantha mentioned, by community workers in the rural areas, the skepticism by the physicians regarding that level. How do you safeguard some of those things and then create a confidence in that level?
Well, first off, I do think most community health workers, if they aren't well-trained, can be well-trained if we make that investment in them. And we can look at something that I think appeals to most physicians, which is being able to make people better. healing Samantha, healing Mohan, and so on. And I think if you begin to think of that as a web that goes out from that physician, okay, so that, yeah, you've got a physician over here, but we've got these 4 community workers who are extending what that physician has as his reach or her reach. I think that's a positive for the physicians, but it's also a positive for the community, because in terms of, you know, routine stuff, you know, the little kid has a sore throat, what exactly does that mean? All these different things don't necessarily need to have a visit to a physician office. They need to talk to somebody. And in some cases, that may just be talking on the phone. And so I pick up a nurse hotline, and I call in and I say, you know, I'm feeling this way. Do I have to worry about something? And, well, tell me about your symptoms. What's been going on the last couple of days, Mr. Ward, blah, 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 blah. And they can pretty much figure out, in most cases, what's up, what we need to do. They can then either hand that care off to a physician or just say, we're done, and off you go. I've been seen, for example, for thyroid monitoring, because I have a wacky thyroid, by a nurse practitioner. I don't need to see a doctor. Heck, I don't even need to see a nurse at all. All I need to do is periodically take a TSH and check it out. And based on that, go ahead and up my dose or down my dose. And a community health worker is perfectly capable of drawing a specimen and sending it off to a lab in Mumbai. They look at it and they go, yeah, he's hyperthyroid, cut back on the amount of Synthroid.
Thanks.
Great, thank you, Bill. Another question. So COVID really exposed a lot of issues with health systems preparedness and capacity worldwide. What would you say was the biggest lesson that you learned from the pandemic in terms of previously unrecognized deficiencies that need to be addressed in this area?
Oh, wow. I think the biggest lesson I got was lock my doors and stay in and not venture out. I think what happened was, at least in what I've seen, is we typically don't run hospitals very efficiently at all. Okay. The average patient takes about 6.5 hours to get through an ER. That's ridiculous. We don't triage well. There are patients who come to ERs who shouldn't be at ERs to begin with. And so we've got a couple of things going on. We've got inappropriate patient demand and we've got sluggish response. And then the pandemic hit. And it was like compounding the madness. The ERs became totally swamped. And we found hospitals doing things like putting up tents out in their parking lots to be able to take care of what they were calling, we call walking wounded. Person who comes in with a runny nose, but I've got to be seen in the emergency room right now because I want my runny nose to stop. Well, go to the drugstore and get some Actifed and your runny nose will stop running. We don't do that. In fact, there are a lot of places around the world where you can go to a pharmacy and the pharmacist will say, oh, this is what's going on. Here, take this, without a doctor's prescription. But we're set up that a doctor has to write a prescription for any kind of medication. That doesn't necessarily need to be the case. And so my hope, as at least in the US, we're starting to come out from under the cloud of this pandemic, is that we will get a group together that will look at how should we have been delivering care in the lead up to the pandemic? How did we deliver care during the pandemic? And what do we need to change? And how do we get to be really, really creative in the way we go about providing service, so that on an ordinary day, you don't have to wait 6.5 hours to get through the ER. You can be in and out in a couple of hours, or you don't even need to go there. You can be seen at a doc in the box, as we call it, an urgent care center, or just at the pharmacy to take care of your medical needs, or on the phone, do a telephone visit. We've also seen, I've seen this as in I've seen videos about it and read some literature about it. There are, what am I going to call it? Virtual visits that are actually visits with a robot. And so I will sign in, and I guess this is connected to artificial intelligence and a few things. I'll sign in and the robot will say, you know, Bill, you sound a little down today. What's going on? Well, my nose is stuffed up, my ears are hurting me, blah, blah, blah. I go, oh, well, have you been taking your decongestant that you were prescribed, 2 weeks ago? No, I kind of stopped taking it when I felt a little better. Well, Bill, you need to get back on it. So that ability, I think, is coming online pretty quickly. And you will, we see it in everything that we do. You make a phone call to United to book a flight, you're talking to a robot. You call a local utility, you're talking to a robot. And so I think with artificial intelligence and some good clinician backup, that kind of thing could happen in healthcare.
Just to chime in again, I think for the people who are attending this program, we just wanted to let you know also that in our development of the programs as we go forward, both on the the degree and then the certificate programs, we are planning to inculcate a lot of elements on artificial intelligence, data, and then the new technology as a part of the public health programs, so that I think the leaders can actually be developed and trained on skill sets which are required in that area, utilizing the programs which are already there in Geo on the artificial intelligence and other areas. Therefore, there is going to be, you are going to see a lot of those newer technologies being included into the training programs to do that. Thanks.
Thank you, Dr. Chalapa. So I think we probably have time for one more question. And I'll make it a biggie, Bill. Give you a tough one. So at the beginning of the presentation, you talked about the 3 key challenges facing healthcare systems today in terms of an overwhelmed healthcare provider sector, resource shortages, and global and local management deficiencies. In your experience, what's kind of, because you worked domestically and internationally, what's been the most important step that can be taken to kind of address these issues? If there's kind of one big takeaway for each one that you kind of found a solution that worked, what was the key action for each?
Well, in terms of staff, it's important to pay attention to the psyche, if you will, of the staff. It's important to make sure they take off, get away, recharge, and then come back. There's a new CEO in Maryland who said to the staff, and they were pretty full with COVID patients, said to her staff, look, you all administrative staff are pitching in to move patients and transport supplies and all that. And I've noticed that a couple of you have canceled your vacations. Stop doing that. You need to get away. You need to clear your head. You need to sort of regenerate, rejuvenate, and then come on back. And we're glad to have you, but please do take your vacation, get away. What I've also seen done is that in some cases with physicians and surgeons, there are actual interventions where, folks from the psych department will go and just sit down with a couple of them at a time and say, what's going on? What's happening? How can we get you away? And that seems to be the thing, getting away for bits and pieces of time. Now, that's really easy to say and very hard to do when you've got staff shortages. So we've got to make sure that we have a way that we can get them to go away for a bit of time so that they can unwind, depressurize, and then come back fully charged. Because I've seen too many times where exhausted providers have made mistakes that were they fresh, they would never have made. And I think that's a problem that we've got to grapple with. And I think that's part of what I mentioned earlier about we should get a group together to ask, how did we handle this pandemic? I know from a public relations standpoint and from a public health standpoint, this is strictly my opinion, we did not handle it really well. The messages were confusing. They were contradictory in some cases. And the public was left to wonder whether they could believe what's being told to them. That's a real problem. We've got to restore the credibility in the system.
That's great. Thank you, Bill. So I will, and thank you everyone for the great questions. I'll pass off to Pranav for the closing remarks now.
Thank you so much, Samantha, and thank you so much, Dr. Bill. That was a great session. I think one probably key takeaway for us is that public health management cannot only rely on the technical and operational sides of things, but also depend a lot on the managerial and also, as you said, the communication side of how things are handled. So thank you so much for that. I'd want to now invite Dr. Deepak Jain, who is the Vice Chancellor of Geo Institute, to give his concluding remarks. He is the European President and Professor of Marketing at the China-Europe International Business School. His influential career spans nearly 3 decades as an educator, a senior business school administrator, and a consultant to corporations and governments. Among the many distinctions for his teaching and service, Dr. Jain has received the Pravasi Bharatiya Samman from the Prime Minister of India, an award that recognizes exceptional leadership contributions of overseas Indians. Apart from his academic and professional achievements, Dr. Jain is a person you can talk to about any topic under the sun, no matter who you are and where you are, and he will always indulge you in conversation and leave you with 2 or 3 key insights, which will stay with you for the rest of your life. With that, over to you, sir.
Thank you, Sanjay. Let me offer my sincere thanks, I would say, to Professor Ward for sharing your insights on this topic of public health management. So, Professor Ward, let me tell you one thing. It was exactly 22 years ago, a person came to see me, and that person's name was Dr. Mohan Chelappa. At that time, I was involved in building the Indian School of Business, like today I am with Geo Institute. And Dr. Chelappa had this insight at that time. And I tell you, at that time, I didn't even know how to spell public health. He says, Deepak, you are creating a school of business. It would be very good if we can create a school of public health management within the school of business. And he saw that particularly for a country like India, it would be very good if we create public awareness. In your talk, you mentioned the quote that a ounce of prevention is better than a pound of cure. For that to happen, we need to educate the patient. We need to have public health education. So your talk, I took 3 major points from your talk today. First was the metaphor of a spider and a cobweb. I think that metaphor of the spider and how the cobweb and spider instincts. And one area that I have just started working on is this area called animal instincts, animal behavior, and human learning. How humans can learn from animal instincts and animal behavior. So I'm reading a lot about ants, birds, and also really these days, and also about honeybee and how they make their nest and others, because there is a lot to learn from them. From birds, you learn about the team culture and how they can create an ecosystem. The second learning to me was your emphasis on people and the teamwork. You said infrastructure matters, technology matters, financial matters, but you circled people. And then you brought this concept of teamwork. And I have always believed as a management professor and as a dean that humanizing business by realizing that people are the only source of differentiation and value creation. Somebody else can build the same infrastructure. Somebody else can come up with the same financial scheme. But people who work for you and work with you, they are your real assets. And you mentioned that very clearly with the circle, and then you brought the teamwork. And the third learning for me was this concept that you brought at the end of artificial intelligence, robotics, and telehealth. Because for a country like India, with 1.35 billion people and being associated with China, in these countries, we cannot do this just based on pure people. Whether it is artificial intelligence, it's robotics, we need to make sure that we make the best use of technology. So let me just call you Bill for a minute, and I tell you, I think there is a new diet, I use the word DIET, for public health management. D stands for digital learning. The only way we can educate people is through learning. You put it in the context of telehealth or whatever it is. The second, I stands for innovative mindset. And you touched on the innovation in your talk. E stands for entrepreneurial spirit. And entrepreneurship to me does not mean creating new business. Entrepreneurship to me is willingness to take risk. And you mentioned that risk taking in your talk. And the T stands for culture. We cannot do it together. The birds, they fly together as a team. They know where the season is, where the warm weather is, and others. So to me, the new diet for our program would be how we build a very strong digital platform, be very innovative, and by innovation, I mean frugal, cost conscious, because we may not have the resources, willingness to take the risk, and build a team culture in the institution. So that's the kind of program that we would like to do. And with Mohan there, and now with your support, I think we can build a very good public health management program in India. Dr. Dawar always has been very passionate from day one when we started the Geo Institute that we need to focus on health. And as he mentioned, that we are also going to have a full-fledged medical school and the whole health sciences and also the whole concept of sports science and sports management. So this Geo Institute, as Prerna said in the beginning, is a very comprehensive institute. And I, just listening to you and Mohan made some remarks and others, this is to me not like doing a program in artificial intelligence and digital learning or digital media. This program is a program of it's a service to the nation. Public health, you don't place graduates at very high salaries. So when I think of this public health management program, in few words, I will describe this as Geo Institute's journey from success to significance. You make successful leaders, but you also need to have leaders who are going to make a difference and who are willing to spend their time on being a leader in the public health management area, because this is a journey of significance, making a difference, not for that may becoming rich and others. This is a service. It's a calling that we all do. And I hope that with your assistance and your guidance and under Mohan's leadership, Dr. Dawar, myself, and all the people involved, we would really make the chairpersons, Mr. and Mrs. Ambani, very proud of what we can build in India. And I really believe that if we have the right thinking, the right reasoning, and have a sound execution plan and have a good evaluation associated with it so that we continuously improve, that to me, the T of thinking, R of reasoning, E of execution, E of evaluation is going to be the human tree, and the shadow of that tree is going to give us the warmth. And very soon we will hear a lot about this program in years to come and days to come. So my sincere thanks on behalf of Geo Institute to everyone. And I look forward to working with you. Though I always have a saying that no challenge ahead of you is greater than the force behind you. So to Dr. Mohan Chelappa and everyone here, I say Deepak Gyani is always behind, and let's all be united, work together and create something that when we reflect back, one day we all will smile and say, I was part of this institute when it was just coming up. Thank you, everyone.
Well said, Dr. Deepak, well said.
Thank you so much, Dr. Jain.
Thank you.
As always, your words are very inspiring to all of us. With that, I think we come to a close to this session of the webinar. Once again, a very, very warm thank you to everybody who's joined us today. I think it was a great session, very engaging one, and the first of many in the public health sector. We'll very soon have another panel discussion on the 17th of March, which is going to be about building brands in the digital age, where we have a panel of very eminent female speakers who have made their mark in terms of building brands right from scratch and also taking into account the technological evolution that's happening in today's day and age. So we look forward to joining you for that session as well. You can follow our social media pages for updates. Once again, thank you for joining us, and I hope everybody has a great weekend. Thank you again.
Bye-bye.
Bye-bye.
Thank you, Sunshine.
Thank you,
everyone.
sir.
Right. Thanks very much, Deepak.
We are
Safe
perfectly
travels.
on time, 8:30.
8:30, perfect timing.
Right.
Good
Thank you.
program.